Morning, everyone. This is David Hurl, for those of you online. This morning, I'd like to welcome everyone to our Spring Conference Showcase. Our exhibitors this morning are Janssen Pharmaceuticals and Pfizer, so please stop by if you're here in person. Our showcase this morning is going to feature 5 speakers. We have a lot of exciting and varied topics. After each speaker, we'll allow a short question and answer period. I'd like to begin with Ann Wong. Her topic this morning is survival of patients paced with leadless versus conduction system pacemakers. Ann graduated from the University of Wisconsin-Madison in the spring of 2022 with a BS in biomedical engineering and an honors thesis in research. She joined MHIF as a summer intern, where she worked with Dr. Sengupta and then accepted a full-time position as a research associate with the Heart Rhythm Science Center for her gap year. She's enjoyed her time at MHIF and looks forward to starting medical school in July. So with that, Ann.
Thank you. Thank you everyone for being here. My name is Ann. I'll be presenting survival of patients paced with leadless versus conduction system pacemakers. I have no disclosures. So at the Heart Rhythm Science Center, we're really focused on studying and treating different arrhythmias of the heart. These arrhythmias can include things like atrial fibrillation, symptomatic bradycardia, sinus node dysfunction, and they can all be indications that a patient might need treatment with a pacing device. These pacing devices can include single or dual chamber pacemakers, which have 1 or 2 leads respectively, as well as leadless pacing devices, which have no leads. And while these devices are great, complications can still arise, such as cardiac dyssynchrony, pacing-induced cardiomyopathy, tricuspid valve dysfunction, implant device complications, as well as lead-associated complications. We can use these devices to pace in many different areas of the heart, such as in the atrium, as well as in the ventricle, where a leadless pacemaker will go. We can also place a lead near the bundle of His, or the left bundle branch to do conduction system pacing, which is what we'll start off talking about today. So conduction system pacing is a novel pacing technique where the lead is placed along the heart's natural conduction system, opposed to pacing in the myocardium. And this has physiological benefits of improving ventricular synchrony. However, its procedural difficulty has really limited its implementation in clinical practice. But with the 3834 French lead, it is smaller, so it makes it easier to implant along the ventricular septum, which has allowed an increase in this technique in the clinic. And as I said before, ventricular synchrony is preserved, but a transvenous lead is required, and so lead-associated complications can occur. On the other hand, Micra leadless pacemakers avoid pocket complications and transvenous lead complications that we normally see with conduction system pacing. These are really great for patients that have significant tricuspid regurgitation, limited vascular access, or are prone to infection. And they're placed in the RV septum, and they do not provide synchronous pacing. So survival benefit of leadless pacing compared to conduction system pacing is currently unknown. So we set out to characterize early survival benefit of these 2 pacing types at our institution. All patients that had a leadless pacemaker or a conduction system pacemaker implanted from January 2010 to March 2022 were included. And then we generated Kaplan-Meier survival curves to compare these 2 patient cohorts' 1-year survivals. We also used a Cox proportional hazards model to assess the association of different comorbidities with our 1-year mortality. So starting off looking at our patient demographics, our 2 cohorts were relatively similar with the exception of significantly more atrial fibrillation in our Micra leadless pacing cohort. We also saw a significant difference in baseline ejection fraction, as well as significantly more chronic kidney disease in our Micra cohort. We also looked at paced QRS duration after implant, as QRS duration is a measurement or indicator of ventricular synchrony. So the more narrow the QRS, the more synchronous the ventricles are contracting. And what we found was that in our conduction system pacing group, our QRS duration was much more narrow than our leadless pacing group, which is what we expected and hoped to see because conduction system pacing is supposed to preserve that ventricular synchrony. So looking at our first curve, this curve shows all comers with the leadless pacing group in red and the conduction system pacing group in blue. And as you can see, we did see a significant decrease in survival in our leadless pacing group. Because we did have a difference in baseline ejection fraction, we kind of wanted to parse this out a bit. And so this figure is looking at patients that had normal ejection fraction, which we consider to be greater than or equal to 55. And still, we continue to see increased mortality in our leadless pacing cohort. Now, we also wanted to look into chronic kidney disease because we had much more moderate to severe chronic kidney disease in our leadless pacing cohort. And when we looked at patients with normal ejection fraction that did not have moderate to severe chronic kidney disease, which we defined as stage 4 or 5, we still continue to see the decrease in survival in this leadless pacing group. Looking at our Cox proportional hazards model, one thing that really stood out to us was history of heart failure as a particularly impactful risk factor. So of course, we do have limitations, including that this was a relatively short retrospective single center study, as well as there were candidacy restrictions for conduction system pacing. For example, if a patient did have significant TR or they were really prone to infection, then they most likely fell into that Micra cohort. As well as there's potential for selection bias against conduction system pacing, just because it is still a relatively new technique. In terms of future work, we're really focusing on characterizing the differences in heart failure between our two cohorts. Right now, we're using a simple yes/no for history of heart failure, indicated by physician's diagnosis in the chart. And so we're looking at potentially going deeper into the type of heart failure, maybe using a specific lab value. But if anyone in the audience has suggestions on the best way to do this, we would love any advice after this presentation. And then we'll also be collecting some additional comorbidities so that we can apply the Charlson comorbidity score, really hoping to kind of determine whether our leadless pacing population is just overall a more sick population than our conduction system pacing group. And then, of course, we're looking to increase the amount and length of follow-up, particularly with our conduction system pacing group. Because it is a new technique, follow-up was more limited. And so by increasing our study date, we'll be able to collect some more data and hopefully create 2-year survival curves, 5-year survival curves, as well as evaluate more long-term clinical outcomes that we're interested in. So overall, the results of our study suggest that conduction system pacing improves short-term survival compared to leadless pacing, regardless of ejection fraction. And it really implies that the preservation of ventricular synchrony that you get with conduction system pacing plays an important role. We also saw that history of heart failure was particularly impactful and a really strong risk factor on patient survival in the leadless population. As well as a leadless pacemaker that is capable of pacing the conduction system is really ideal. So we look forward to seeing advancements in technology in the coming years and how we could potentially use a device like that to continually improve care for our patients. I'd like to acknowledge the support of the Joseph F. Novogratz Family Heart Rhythm Center, and I will now take any questions.
Do you have any data about the RV function and the tricuspid regurgitation?
Yes, so we looked at tricuspid regurgitation change, and we haven't included it yet just because a lot of our patients had limited echo follow-up, and so our sample size was pretty small. But we are looking at change in tricuspid regurgitation over time, as well as change in EF from baseline to future follow-up visits. So hopefully when we get some more of that follow-up data, we'll be able to look more into that.
All right. Thanks very much, Ann. All right, next up we have Dr. Atsushi Okada on the usefulness of preprocedural computer tomography in surgical aortic valve disease. Dr. Okada is a research scholar with the Minneapolis Heart Institute Foundation's Valve Science Center. He received his medical degree from Chiba University of Medicine in 2009. Before coming to MHIF, Dr. Okada completed his cardiology fellowship at the National Cerebral and Cardiovascular Center in Osaka, where he also worked as a cardiology attending physician. Dr. Okada's primary interest is heart failure and non-pharmacologic treatments, with a main focus on valvular heart disease, cardiomyopathies, including recent interest in cardiac amyloidosis. That, Dr. Okada.
Thank you for your introduction. My name is Atsushi Okada. I'm a originally interventional cardiologist. I work with a surgeon here, which is very exciting. And my talk is about surgical aortic valve sizing. We know that in particular in aortic stenosis, we have two options for treatment, which is transcatheter aortic valve replacement, TAVR, or surgical aortic valve replacement. And currently, the valve size selection is done in two different ways in both of these treatments. In TAVR, we use a CT scan and we measure the aortic annulus exactly by using CT. And the figure below is the manufacturer prepared figure that shows you the CT measurements, which corresponds to the valve size that is recommended to use. So in TAVR, it's done by using CT, and it's decided before the procedure. And the good point is that there's no operator bias in this. When it comes to SAVR, currently the methods is using these sizers on the table during surgery. and, and this may result in variation between operators. And how we could apply CT sizing to SAVR is not understood, and which is the topic of this research. So our hypothesis was that applying CT sizing for SAVR would lead to less operator bias and improved valve selection compared to the conventional sizer methods. To look at this hypothesis and aim, we are looking at two different cohorts. The first cohort is a retrospective cohort evaluating the relationship between CT annulus size and the actual implanted valve size. And the second cohort, starting from June 2022, which I started to work here last year, we're comparing the CT annulus size with actual sizing during SAVR using a thing called Hager dilators, and also how the valve was classified, which depending on this cohort, which I would mention in a minute. So the Hager dilators is a figure shown in the right bottom. It's kind of a stick that comes in 1 millimeter that Dr. Bapat often uses to size the valve during surgery. So the first cohort, we looked at 371 patients who had surgical AVR from 2019 to 2021. So by excluding patients with previous aortic valve surgery, aortic root enlargement, and patients who did not have a pre-op CT, we ended up in 246 patients with CT. And to ease the interpretation of our results, the patients who had mechanical valves and tissue valves other than these three valves, which was a small number, was excluded, and the final population is from 199 patients. So we built up this this table here. On the left is the CT derived size. And for example, the CT measure was 20.0 or between 20.0 and 21.9. The minimum SAVR valve size that could be predicted by CT was 21. So that's the way that we compared the value from CT and the predicted CT size and then the actual SAVR that they received. And the classification was these three. Number one is that SAVR that CT predicted was larger than the actual SAVR. The second is that CT was equal to that actual SAVR size. And number three, CT was smaller than the actual SAVR size. So in terms of my hypothesis here, the rate of the first number one classification should be smaller by using CT sizing. So the first cohort is a retrospective cohort that I looked at. And this is the key figure of the results here. On the horizontal axis is the SAVR valve size that they received. On the vertical axis is the CT size. And you can see here that there's a lot of variation here, and the CT size, for example, if you take a CT derived diameter 25, we can see that a lot of patients are receiving a lot of various size of valves. And this color here on the red or pink is the patients who had CT sizing which was larger than the actual size, and that was seen in 42% of these patients. So now I looked at what is the difference between these three classifications. And when we look at that, the patients on the left column, which is the CT was larger cohort, we see that those are patients who had larger annulus size and also larger sinus of Valsalva and sinus ST junction diameter, which means that aortic valve anatomy was larger in these patients. Another factor that was noticed are operator bias that was previously hypothesized. And on the bottom, you can see that we have 8 operators here, but we can see that there's a operator variance here. So to summarize the first cohort, the relationship between CT annulus size and the implanted SAVR size showed a large variation, and 42% of the cases were classified as CT larger than the actual SAVR. In other words, CT predicted minimal label size that was larger than the actual SAVR that received. And what was related to this was larger annulus size and operator dependency. So for the second cohort, which is the CT sizing cohort that we are working on now, so from June 2022 to December 2022, we looked at SAVR. We started with patients with bicuspid aortic disease. So we compared the CT annulus size and the true annulus size during SAVR using Hayward dilators and that classification of that valve selection. The results here, the first figure is showing the CT-derived annulus size and the true annulus size during SAVR, which you can see that this is a very strong correlation shown here. And in terms of the valve selection, the left is the cohort 1, the right is the cohort 2, which is CT and Hager sizing. And you can see that the classification of the valve selection is improved here. So CT-derived annulus size strongly showed correlation with Hager dilators during SAVR, and it validates that CT sizing does correspond to the annulus size. And applying the CT sizing led to lower rates of CT being larger than the actual SAVR size. So in conclusion, using that conventional methods, which is using sizers during surgery, showed a large variation in operator dependency, and over 40% could have had a larger SAVR valve based on CT sizing. And when we apply these methods to SAVR, the CT measuring to SAVR, we saw a strong correlation with true annulus sizing during SAVR, resulted in lower rates of CT larger than the actual SAVR size. So further, this may be useful for predicting patient prosthesis mismatch and the necessity of aortic root enlargement prior to surgery. And with that, I'm open to questions. Thank you. Yes.
That was a really nice talk. I was wondering if you were able to see a difference between perivalvular leaks in the two procedures, and did they correlate with the CT fount versus the SAVR fount?
So thank you for the question. So your question would be that after the surgery, was there a difference in perivalvular AR by the sizing or the classification? Is that correct?
Right.
Yeah. So actually, we did look at aortic regurgitation, but we did not see any difference between them. Actually, the rates that had AR was pretty small, so there's a limitation there. But to answer your question, we did not see any difference. Thank you.
Yes. Atsushi, a great topic, and congratulations for this work. So leading to that last slide that you talk about, could this lead to less BPM? Do you have objective data to show on the cohort 1 what was the rate of your average EOAI versus the second cohort?
Yeah.
And was there more root enlargements done as a consequence now by following what the CT had determined?
Yeah, thank you for your question. So for the second question, for root enlargement, currently this data is excluding all patients who had root enlargement. Because we're kind of in a investing phase for this. So I do have data from PPM post-operative EOAs, and clearly that second cohort, the way we do with the CT, decreases the rate of PPM. Yes.
Thank you for that presentation. We do have a question in the Q&A pod online from Dr. Lesser. Excuse me, he asked, why not just use Hager assessment and not the CT? Apologize if that's not the correct pronunciation.
Yes, thank you for your question. So the current sizer that I showed are in the surgical field. It's a manufacturer prepared sizer. And the annulus is not a complete circle, and that could lead to the mismatch of sizing. And the Hager dilators, from my understanding, is originally developed in the field of gynecology to measure things or expand things in that field. And I think that's one way that could be proposed, but I don't think that is used widely in the field of surgery now. Thank you.
Our next presenter this morning will be Hideki Koike, speaking on the association of extracellular volume and global longitudinal strain assessment by CT with post-TAVR outcomes. Dr. Koike is a research scholar with Minneapolis Heart Institute Foundation's Cardiovascular Imaging Research Center. He is from Tokyo, Japan, where he was a practicing cardiologist and assistant professor at Toho University, the same school where he earned his medical degree in 2009. He is a member of the Japanese Society of Internal Medicine, Japanese Circulation Society, and the Japanese Heart Rhythm Society. Dr. Koike joined MHIF in August of 2021. Dr. Koike.
Thank you for the great introduction. Today, I would like to talk about association of extracellular volume and global longitudinal strain assessment of assessment by CT angiography with post-TAVR outcomes. Yep. Now, this is the background. Non-invasive assessment of ECV and marker of myocardial fibrosis by CMR and CTA has provided important insights into the pathophysiology of myocardial involvement. It is highly associated with higher risk of all-cause mortality and composite outcomes. GLS reflects cardiac contractile dysfunction beyond the preserved VEF. CTA is commonly used for TAVR planning. The feasibility of ECV and GLS by CTA was demonstrated in severe AS patients being evaluated for TAVR. However, the comprehensive CTA assessment combining both markers has not been adequately standardized. We aim to evaluate whether the combination of these parameters could be leveraged by a comprehensive CTA assessment and help the risk stratification of contemporary cohort of predominantly low-risk patient undergoing TAVR patient. This is the method section, and the consecutive patient with severe aortic stenosis who underwent TAVR CTA assessment with pre-contrast and 3-minute delayed acquisition for ECV measurement were included between January 2021 and June 2022. In addition to the usual TAVR planning, CTA protocols, 3-minute delayed acquisition were performed to assess ECV. Dedicated software for post-processing of CTA-derived ECV and GLS was used. For ECVs, the software created a subtraction image from pre-contrast and post 3 minutes delay phase CT by using automatic 3D non-rigid image co-registration. CT-ECB expressed as a percentage was calculated below the formula using the delta Hounsfield unit and hematocrit. After generating the whole ECB maps, ECB values were measured using the mid-Zepta manual ROI tracing. For strain analysis, CTA strain values were assessed offline using the dedicated feature tracking software. 3 long-axis views, 4-chamber, 3-chamber, and 2-chamber, were manually reconstructed using the 3D double oblique multiplanar reconstructions. After that, outlining of endocardial and epicardium border was manually drawn in each view at end diastole and end systole, avoiding the inclusion of mitral annulus, papillary muscle, and LV outflow tract areas. Then software automatically calculated the strain values by feature tracking propagation throughout the whole cardiac cycles. Clinical imaging characteristics were collected from the chart review. All patients received commercially approved TAVR devices. All-cause mortality and composite outcome defined as cardiac death and heart failure hospitalization were collected. To evaluate the combination of ECV and GLS, patients were divided into 3 groups according to the median value of ECV and GLS. Non-ECV non-group, this blue boxes shows the non-ECV non-group means the ECV less median and GLS strain value less than median. Either group means the ECB above the medians or GLS above the median, and both had ECB more than median groups and GLS more than median. The patient characteristics and outcomes among the 3 groups were assessed. Now move on to the results section. Study workflow shown in figure 2. Finally, 300 patients were assessed for prognosis. Median CT-ECB value was 28.5% and GLS were negative 20.1%, matching the threshold associated with increased risk on restricted cubic spline curves. Patient characteristics according to presence of either CT-ECV and or GLS above the median were shown in table 1. There were no significant difference in NYHA. However, both groups had a significantly higher risk background among the 3 groups, such as age and STS PROMA score. Compared to echo parameters, LVEF, LAVI, LAVI, and AV area were significantly worse in the either and both groups, although the mean AV gradient and presence of other valvular disease did not differ. LV volume, LVEF, ECV, and GLS values from CTA were also worse in either and both groups. Over a median follow-up of about 1 year, 32 deaths and 44 composite outcomes occurred. Univariate and multivariate Cox hazard analysis was shown in table 2 and table 3. Because of the space of the poster, I show the main values in the tables. AF, STS score, and other valvular disease were associated with composite outcomes. Adjusting for the other comorbidities, multivariate Adjusting for the other comorbidities, multivariate Cox analysis demonstrated the association between the abnormalities of either and or even more. So both CT parameters with cardiac death and heart failure hospitalization post-TAVR. I will summarize the result. This is the main figures. Comprehensive pre-TAVR CT assessment, including the ECV and LVGLS related to short-term outcomes in the contemporary cohort of low-risk patients with preserved LVEF. From these Kaplan-Meier curves, the combination of the worst components of LVGLS and ECB group increased the all-cause mortality and significantly increased the risk of composite outcomes. I will conclude this presentation. Baseline comprehensive CTA assessment of ECB and GLS is feasible and provided independent association with 1 year post-TAVR cardiovascular outcome in contemporary and predominantly low-risk cohort. Future study in emerging TAVR cohort could explore the incremental role of these biomarkers for improving the risk stratification, timing of intervention, and tracking the response to the treatment. Thank you so much.
Thank you. I just have a question, and maybe you answered this, but what is the relationship between extracellular volume and LV mass in this whole?
Okay, thank you for good questions. In this study, this actually I calculated I collected the LV volumes in each groups, but there are no significant difference between the LV volume in the three groups. So the ECB values among the three groups are significantly different. So it give you difference. Usual the impact of the LV volume.
Scott, to your point, the LV mass correlation with ECV was very weak.
Oh, it was.
It was weak. It's like 0.3 point something,
Thank you.
0.3
That's
something.
what that was.
Yes, so it's weak. It's a combination of the valvular issues plus many other things by the time they get to the procedure, but yeah, it was weak.
Thank you.
Thank you. Our next speaker this morning is going to be Spyridon and Costantinis on the impact of calcium on procedural techniques and outcomes of chronic total occlusion, percutaneous coronary intervention, insights from the PROGRESS-CTO registry. Spyridon is a postdoctoral research fellow at the Minneapolis Heart Institute Foundation Center for Coronary Artery Disease. Dr. Kostantinis joined MHIF from Athens, Greece, where he obtained his MD from the National and Kapodistrian University of Athens in 2019. Following graduation from medical school, Dr. Kostantinis worked as a rural physician in his hometown of Trikula in Greece. His research focus includes chronic total occlusion intervention, complex high-risk intervention, and bifurcation disease interventions. Welcome.
Thank you so much, Dr. Haro, for the introduction. Good morning, everyone. Thank you for the opportunity to present today our work on behalf of the PROGRESS-CTO investigators entitled Impact of Calcium on Procedural Techniques and Outcomes of CTO PCI. We presented this work as an award-winning abstract presentation on CTO Plus conference in New York City last month. I have no financial disclosures. Coronary calcification is common and often increases the difficulty of CTO PCI. Calcification can hinder wire advancement and wire penetration, as well as equipment delivery and stent expansion. Our goal was to examine the impact of calcium on the procedural techniques and outcomes of CTO PCI in a large multi-center registry. The prospective global registry for the study of chronic total occlusion interventions, or PROGRESS-CTO registry, is a prospective observational multi-center registry. PROGRESS-CTO currently includes more than 13,000 procedures from 69 participating centers from 10 countries worldwide, and Minneapolis Heart Institute Foundation is the coordinating center. Here is the map of the US sites that are part of the registry, and here is the map of the international sites that are part of PROGRESS-CTO. We use standard statistical methods for our analysis. Here we can see the classification of coronary calcification that we used, and we classified the calcification in two groups, the moderate severe calcification group and the none to mild calcification group. In the present study, we analyzed 12,344 CTO PCIs performed at 44 centers between 2012 and 2022. Moderate to severe calcification was present in 47% of CTO lesions. Patients whose lesions were calcified were older and had higher prevalence of comorbidities such as hypertension, diabetes mellitus, dyslipidemia, heart failure, cerebrovascular disease, and peripheral arterial disease, compared with patients with no or mild calcium. Also, they were more likely to have had prior PCI and prior coronary artery bypass graft surgery. Calcified lesions were longer and more complex with higher JSTO score and PROGRESS-CTO score compared with mildly or non-calcified lesions. Calcified lesions required more frequent use of advanced CTO PCI techniques such as the retrograde approach, 40% versus 24%, and the ADR, 27% versus 16% compared with lesions with no or mild calcium. IVUS was also used more frequently among calcified lesions, 60% versus 42%. Interventions in the moderate severe calcium group required longer procedure time and fluoroscopy time, higher air camera radiation dose, and they required more frequently the use of a left ventricular assist device. Balloon angioplasty was the most common lesion preparation technique for moderate severe calcified lesions, followed by rotational atherectomy in 7.1%, laser atherectomy, angiosculpt, intravascular lithotripsy in 2.7%, and orbital atherectomy in 1.5% of calcified lesions. As we can see in the two pie charts of the final successful crossing strategy, the retrograde approach was more frequently the final successful crossing strategy among moderate severe calcium group, 23% versus 15%, compared with mild or non-calcified lesions. Same was for the ADR, 15% versus 11%. Technical and procedural success rates were lower among lesions with moderate severe calcium. For technical success, 83% versus 90%. For procedural success, 81% versus 89%. And the incidence of MACE was also higher among calcified lesions, 2.9% versus 1.2%. High rates of MACE in calcified lesions were mainly due to perforation that resulted to tamponade requiring pericardiocentesis, but also due to higher rates of repeat PCI, acute MI, and also death. As we can see in the forest plot here, a multivariable analysis on technical success, moderate severe calcification was independently associated with lower technical success even after adjusted for multiple clinical and angiographic factors. Here are the results of the multivariable analysis on MACE, and as we can see, the calcification was independently associated with higher MACE. Our study has limitations. It is an observational registry without adjudication of clinical events by an independent committee. Quantitative coronary angiographic analysis were not performed, and interventions in the PROGRESS-CTO registry are performed at high-volume experienced centers, limiting the generalizability of the findings to centers with less CTO PCI experience. In conclusion, moderate severe calcification was present in 47% of CTO lesions and was associated with higher utilization of the retrograde approach and the ADR, lower technical and procedural success rates, and higher incidence of in-hospital MACE. These are our acknowledgements. This is the list of our co-authors. Thank you very much for your attention. I will be happy to answer any further questions. Yes.
Very nice data. I have a question in regards to the comment that you made about the percent use of rotational atherectomy and other techniques. Is that lower than expected for a calcified lesion, or is that in agreement with what it's currently done for other PCIs, non-CTOs?
I think in CTO PCI we use more of these devices like rotational atherectomy or IVL. Than regular PCI. We haven't done any comparison between because we don't have data for CTO PCI. We only use data from CTO PCI, but I think data shown in the literature, but those devices are used less frequently for non-CTO PCI than CTO PCI. Thank you very much for the question. Yes, Dr. Sharkey.
Great job, girls. What can be done about this? What are the implications of your findings in terms of, if I had to say so what can you do to reduce the complication rate?
Yeah, that's a great question. I think that the most important is if we decide to do a procedure like that in a non-experienced center, probably we can have a proctor in our center to help us with some complex cases, because calcification is present in a lot of the scores that we already created. So this is an important topic. So for example, let's say that we have a patient with a lot of comorbidities, we have a patient with calcification or other angiographic difficulties. It would be better to refer that patient to more experienced centers or to have a proctor in our center to help with this thing. That's a great question.
Thanks very much. Our last speaker this morning will be Athanasios Rempakos on the impact of lesion length on the outcome of chronic total occlusion percutaneous coronary intervention, insights in the PROGRESS-CTO registry. Dr. Rempakos comes to us from Athens, Greece, where he obtained his MD from the National and Kapodistrian University of Athens in 2021. Currently, he's a research scholar at the Center for Coronary Artery Disease at the Minneapolis Heart Institute Foundation. In his role, Athanasios works on various CCAD2S projects, including Rebirth, GEOCT, NASA, PROGRESS-CTO, Progress Bifurcation, and Progress Complication, among others. With that, welcome.
Thank you very much for the introduction. I'm very happy to present today on behalf of the Progress-CTO investigators our work on the impact of lesion length on the outcomes of CTO PCI, which was presented last month as an award-winning abstract at the CTO Plus conference in New York City. And I want to thank MHIF for the opportunity to present both today at the Grand Rounds and at the conference last month. I have no financial disclosures. So lesion length is a parameter of both the JCTO score for predicting successful guide wire crossing within 30 minutes, and as well as the open clean score for predicting perforation in CTO PCI. The aim of our study was to examine patient and angiographic characteristics associated with longer CTO occlusions, as well as the impact that lesion length has on the outcomes of CTO PCI. This was done in the prospective global registry for the study of chronic total occlusion intervention, or PROGRESS-CTO, which currently includes more than 13,000 procedures from 69 participating centers from 10 countries worldwide. This is a map of the US sites. And this is a map of the international centers in our registry. We used standard statistical methods for the analysis, and the cutoff of 20 millimeters was used to divide the study lesions into two groups based on their length, long lesions longer than 20 and short lesions shorter than 20 millimeters. We examined the baseline clinical and angiographic characteristics, as well as the procedural outcomes of 10,335 CTO PCIs performed at 42 centers from 2012 to 2022. Results revealed that there's a high prevalence of long lesions, with 70% of the study lesions measuring longer than 20 millimeters in length. Patients with long lesions were more likely to be men and had a significantly higher prevalence of comorbidities. Forgot to mention that they were also more likely to have a history of prior MI and prior CABGs. The right coronary artery was more frequently the CTO target vessel in the long lesion group. And additionally, patients with long lesions were more likely to have other unfavorable angiographic characteristics, such as proximal cap ambiguity, side branch at the proximal cap, blunt or no stump, moderate to severe calcification, and moderate to severe proximal tortuosity. and advanced crossing strategies such as antegrade dissection and re-entry or the retrograde approach were more commonly used in the long lesion group. PCI for long CTOs was more frequently associated with crossing failure, and also long CTOs were more often balloon undilatable. Procedure time, fluoroscopy time, air camera radiation dose, and contrast volume were all significantly higher in the long lesion group. Technical and procedural success rates were both significantly lower in cases with long lesions. Technical success was 84.4% in the long lesion group versus 91.8% in the short lesion group, and procedural success was 81.9% in the long lesion group versus 90.3% in the short lesion group. When it comes to in-hospital MACE, the incidence was higher in the long lesion group, 3.4% versus 1.9% in cases with short lesions. For in-hospital complications, acute MI, perforation, and dissection or thrombus were all significantly more common in patients with long lesions. Increasing lesion length, analyzed in increments of 10 millimeters, was associated with a stepwise decrease in technical success rates and an increase in hospital MACE rates. Multivariable logistic regression analysis was performed to evaluate the effect that occlusion length has on technical success and MACE while accounting for potential confounding factors. Results revealed that lesion length is an independent predictor of both technical failure and MACE. Our study has limitations. It is an observational study without adjudication of clinical events by an independent committee. Core lab analysis was not performed, and the operators in the PROGRESS-CTO registry are very experienced in performing CTO PCI, and thus potentially limiting the generalizability to centers with less experience. In conclusion, our study highlights the following key findings. Long CTO lesions were highly prevalent, making up 70% of CTO PCIs in our registry. Long lesions were associated with comorbidities and complex angiographic characteristics. Advanced crossing strategies were more frequently required for the treatment of long lesions. And lastly, long CTOs were independently associated with lower technical success and an increased incidence of complications. Those are our acknowledgements, and those are the co-authors of the study. Thank you so much, and I'm happy to answer any questions.
Thanks very much. Well, thank you everyone for attending this morning. This is great to hear from our scholars and Anne, and thanks again for attending. Have a great week, and the speakers will be around if they have any further questions for them. Okay.